Thank you for inviting me to speak at the KDIGO Implementation Summit, and thank you for hanging around. So today I would like to share with you all today on the cost effectiveness of integrated care models, diabetes care models. So we're going to talk about money and quality of life. So yeah. Here's my outline for today. We'll first talk about the importance of cost effectiveness evaluation in healthcare settings. So globally, there's an increasing trend in healthcare expenditures in the past 2 decades. This graph looks at how healthcare spending as a proportion of the country's GDP has varied over the last 20 years. Healthcare spending as a proportion of the nation's wealth has been increasing. Healthcare expenditures in the US were markedly increased when the coverage expansion began in 2014 as a result of the Affordable Care Act, and healthcare expenditures in China, South Korea, Japan, France, and Australia continues to increase at different rates, whereas countries such as Canada, UK, and Germany starts to plateau or decrease in its healthcare expenditures. Reasons for these change in healthcare expenditures are not limited to policy changes, demographic changes, new technologies, and health sector inflation. So, does spending more improve health outcomes? The answer to this question isn't quite clear-cut. In this graph, we have life expectancy in the y-axis, and on the x-axis, we can see how much each country spends per person on healthcare, adjusted for cost of living. And on the right, at the most right, you can see that North America actually spends the most, though it does not achieve the highest life expectancy. And developing African countries spend similar amounts, but achieve varying life expectancies on the left bottom. Health life expectancy might not be directly related to income. It is just not how much is spent, but how it is spent on. So if 90% of the money is being spent on 10% of the population, then life expectancy will be affected accordingly, even if the 10% of the population are in excellent health and live to an old age. So we have seen that healthcare spending is rising, different countries are spending various amounts on healthcare, and the relationship between extra spending and better health is not very clear. So how does economic evaluation fit into here? So economic evaluation is a comparison of alternative treatment options in terms of their costs and outcomes, which assist decision makers in determining how to allocate limited resources to care for the sick, promote and maintain health. Costs considered include direct medical costs, such as medication and inpatient costs, and also there's indirect medical costs, such as productivity loss and caregiving costs. As for outcomes, we measure health effects of interventions through life years lost and quality adjusted life years. And QALYs is actually a product between expected life years and quality of life. So we take a comparative methodology and measure the incremental cost effectiveness ratio, which we call ISA. This is the difference of cost spent over the difference in health outcomes to provide a ratio of extra cost per extra unit of health effect for the more expensive therapy versus the alternative. The ISA will then be measured against willingness to pay threshold, which differs by country. So for example, in UK, the willingness to pay threshold accepted by NICE for the reimbursement of a drug would be around £20,000 to £30,000 per quality adjusted life year. For countries or jurisdictions that don't have a willingness to pay threshold, such as Hong Kong, we would use a WHO recommendation, which is a willingness of pay of 3 times of our GDP. So now let's take a look at the application of cost effectiveness analysis evaluating novel drugs in type 2 diabetes. So we've heard just now about all the significant effects of these new drugs, and we know from literature that a sustained weight loss for more than 10% overall body weight in people who are obese may actually improve a lot of NCDs such as type 2 diabetes, hypertension, fatty liver disease, and luckily within these past 5 years, weight loss reduction events of novel anti-diabetic drugs are close to what is seen in surgical interventions. GLP-1 receptor agonists and SGLT2 inhibitors, initially developed for the treatment of type 2 diabetes, have demonstrated additional effects for weight loss. In this recently published study in Lancet around February, a research team compared 3 types of drugs, liraglutide, semaglutide, and tirzepatide, to lifestyle interventions and invasive surgical procedures such as bariatric surgeries, and from results of multiple clinical trials. And novel anti-diabetic medications resulted in more than 10% of these weight losses in more than 2/3 of the clinical trial participants. These non-invasive novel medications are nearly as effective as surgical procedures, and they are much more effective than lifestyle interventions alone. So in this SURMOUNT-1 trial, 72-week trial of 2,539 adults with BMI of 30 or more and at least one weight-related complication, after 2 weeks of screening period, participants were randomly assigned to receive tirzepatide at dose of 5 mg, 10 mg, and 15 mg or placebo, administered subcutaneously once weekly for 72 weeks as an adjunct to lifestyle intervention. Tirzepatide of different dosages in adjunct to lifestyle interventions yielded to 15 to 20% percentage change in body weight as compared to 3.1 body weight change to placebo alone. So in a cost-effectiveness study published in January, tirzepatide was more cost-effective over semaglutide, which was modeled based on the SURPASS-2 trial of 1,876 obese patients with type 2 diabetes who were inadequately controlled with metformin, maximum metformin of 1,500 mg per day, mean BMI of 34.2, mean age of 56.6 years old, and HbA1c of around 8%. All 3 doses of the tirzepatide were cost-effective, passing the US willingness to pay cutoff in this study, $100,000 per quality. However, in another CEA studies, it showed that SGLT2 and GLP-1 receptor agonists were not cost-effective as first-line therapy, as compared to metformin alone. The first-line injectable GLP-1 receptor agonists cost more and reduced QALYs compared to metformin. Although QALYs gained were higher in oral GLP-1 as compared to injectable GLP-1 due to the disutility contributed to injection. Oral GLP-1 were still not cost-effective as compared to metformin in a first-line therapy, which is much higher than the willingness to pay threshold in this study, $150,000 per QALYs, as mentioned in this study, and same for SGLT2. To be cost-effective as first-line therapy, with a willingness to pay of $150,000 per QALY, costs of SGLT2 have to be under $5 per day and $6 per USD per day for oral GLP-1 receptor agonists, which is at least 70% of the price cut. I mean, this is actually a US study, and as Dr. Nikhil Tandon previously said, US prices are sometimes inflated. And also, for the pharmaceutical companies, drugs are very hard to be passing the phase 3 clinical trials. So 60% of the trials of the drugs will fail in phase 1, 40% will fail in phase 2, and 40% will fail in phase 3. So it's very hard to get these miracle drugs out there. So we can use cost effectiveness analysis to actually balance with the limited resources of the policymakers, and also balance the sunken costs that the pharmaceutical companies have when they do their R&Ds. So now let's take a look at our study on diabetes complications impact on quality of life patients in type 2 diabetes in Hong Kong. So health technological agencies often recommend to measure quality of life using an EQ5D questionnaire developed by the Euroqual. EQ5D has 5 domains, which includes mobility, self-care, usual activities, pain or discomfort, and anxiety and depression. There are different versions of this questionnaire. So there's 3L for 3 response options per domain and 5L with 5 options. Here's an example of the EQ5D, 3L on the left and then 5L on the middle. 5L has 2 more additional response levels than 3L to improve the descriptive richness and discriminatory power. The descriptive system section of the EQ5D questionnaire produces a 5-digit health state profile that represents the level of reported problems in each of the 5 domains of the health. So these health states can be converted into a single index value using one of the standard EQ5L value sets specific for country and jurisdiction that you're evaluating the technology in. And these value sets represent the preferences of the general populations, with the value sets anchored at 1, representing full health, and dead equals to 0. And the derived single utility score can then be used in the QALY calculations. Choosing a 3L or a 5L version in your study depends on the timing, comparability, and sensitivity translation version, and value set availability in your country. And then in contrast, the EQ VAS visual analog scale scores records the respondent's own assessment of their health status. So it is not anchored on a valuation set. And furthermore, EQ VAS, the scores are anchored on 100, which is the best health you can imagine, and 0, which is the worst health you can imagine. So in our local quality of life study, we analyzed patient records in JADE platform. The JADE technology is a web-based diabetes risk assessment program established in 2007. It is an extension of the Hong Kong Diabetes Register established in 1995 by Professor Chan, and it is a part of a research-driven quality improvement program in Prince of Wales Hospital. The data recorded during the nurse-led structured assessment include medical history, physical examination of the eye and feet, self-care practices, lab investigations, and patient-reported outcomes, including but not limited to quality of life measured using EQ5D3L. Between 2007 and 2018, 20,787 patients with diabetes aged 18 years or above from 2 public hospital diabetes centers and a CUHK affiliated private diabetes center where patients were referred by private doctors or through self-referral, underwent a structured assessment. And using a unique identifier, the JADE database was linked to a territory-wide Hong Kong Hospital Authority electronic medical records to retrieve the clinical outcomes using hospitalizations and including death. So 84.8% of our participants responded to the EQ5D3L questionnaire. Among the 5 EQ5D domains, 29.9% of our patients reported some or severe problems in pain or discomfort, 18.9% for anxiety or depression, 9.5% for mobility, 6.7% for usual activity, and 3.2% for health self-care. So here are the mean EQ5D utility scores. And the mean EQ5D utility score for this study was 0.6860, and 59% of the patients reported full health. Patients experiencing most of these complications will have a decrease in quality of life utility. And large dips in quality of life utility were observed in the year of occurrence of a hemorrhagic stroke, ischemic stroke, CKD stages 3 and 4, and end-stage renal disease without renal replacement therapies, peripheral vascular disease, and lower extremity amputations. Although EQ5D utilities gradually improved over time, it rarely recovered to utility levels before the occurrence of the event. So prevention is very important for diabetes patients. So we use generalized linear models and to evaluate the association between clinical complications of EQ5D local tariffs. Time categorization of events were combined if there were fewer than 10 events in each level, or if there was no evidence on difference between the temporal EQ5D utilities. Age and duration of diabetes, socio-demographic characteristics, comorbidity risk, and clinical risk factors measured at time of questionnaire response was adjusted for in this model. For cardiovascular events, the largest EQ5D utility decrements were observed in the year of occurrence of a hemorrhagic stroke, followed by ischemic stroke, and lower extremity amputation, and congestive heart failure. For renal events, utility decrements were nearly double for those in end-stage kidney disease without renal replacement therapies as compared to those in CKD stages 3 and 4 without renal replacement therapies in the year of event. Most of the patients who experienced a cardiovascular renal event had significant residual impacts of the quality of life, and they seldom returned to pre-event state. Patients who suffered from congestive heart failure or ischemic stroke experienced significant detrimental impacts on quality of life, which persisted for 2 years and then remained static. Whereas for chronic kidney disease, it also decreases health-related quality of life in subsequent years after event occurrence. For end-stage renal disease without renal replacement therapies, we did not have enough patients for calculating the temporal quality of life decrements. The detection of sensory neuropathy during the assessment was associated with worse quality of life decrements than those with visual problems only. And for the latter, quality of life decrements was worst with blindness, followed by severe visual impairment and history of eye treatment. Patients with higher comorbidity scores were also associated with an increase in quality of life decrement. These local Hong Kong quality of life decrements are crucial parameters for us to develop an individual patient-level cost effectiveness model in Chinese patients. I'll now introduce to you our in-house developed individual cost effectiveness model, the Chinese Diabetes Outcomes Model, CDOM. So lifetime cost effectiveness models are often used in evaluating chronic disease interventions. And individual patient models are actually better than cohort cost effectiveness models because they fit in individual patient demographic and clinical characteristics, whereas cohort, you only utilize the population means as output. Individual patient simulation models can capture patient heterogeneity. It is a more accurate representation of the true population and precise estimates on costs and benefits of interventions. It also allows granular analysis of subgroup high-risk populations of interest, such as by age, gender, and BMI. And IPD models also overcome the memoryless property of cohort models, where they remember the patient events histories in previous simulation cycles, and which is very well suited for a long-term cost effectiveness analysis. Though the IPD models require high level of expertise to design and implement, it requires also high computational power and depends on data availability. So we developed this CDOM model in 2010. This is the first individual patient simulation in the Chinese patients, and it was built on the data from 9,506 patients with type 2 diabetes enrolled in the HKDR between 1995 and 2007. The clinical endpoints were censored in 2009, and it was retrieved from the HACMS. The NCD endpoints that we included in the model include coronary heart disease, congestive heart failure, stroke, hemorrhagic stroke, peripheral vascular disease, amputation, chronic kidney disease, end-stage renal disease, cancer, and severe hypoglycemia. Demographics, risk factors, and drug treatments were also adjusted for in the model. Patients would then be simulated by a yearly cycle until the end of the specified cycle years or when they are dead. And in each year, we would randomly order our risk equations for each event and run the risk equations. And the events would then be simulated, and we would update the patient event history, age, diabetes duration, and risk factors in each cycle. If the events led to a death of a patient in the simulated year, then we would exit the simulation. So I will now illustrate the application of the CDOM model in evaluating a long-term cost effectiveness evaluation of the JADE integrated diabetes care program in the Hong Kong setting. Other than evaluating drug treatment, CAA models can be evaluating care models. So let's look at a local case. In 1995, our team developed a multi-component integrated care system to transform busy clinics to a day center, design protocols, and train nurses to evaluate patients with diabetes systematically. The data was systematically recorded in the HKDR, which was a system that was digitalized into a JADE web-based diabetes risk assessment platform in 2007. We used the collected personalized data to empower and engage the patients while doctors use the data to make diagnosis and decision and prescribe drugs. These data-driven actions aim to achieve ABC targets and ensure patients put on life-saving medications. At the same time, the register also provides benchmarking, tracks outcomes, and identifies unmet needs. The JADE web-based platform incorporates the risk engine to enable periodic measurement, monitoring, and management of the patient with diabetes with issue of a personalized report and complete with risk category, trends, targets, decision support. Using this unique report, the care team can educate and empower and engage these patients while the doctors can personalize care guided with contemporary evidence and practice guidelines. The JADE integrated care approach is very similar to what the integrated care approach that is recommended in the KDIGO guidelines. It emphasizes a multi-component integrated team-based care that utilizes IT to promote communication and feedback between non-physicians and physicians within the team. And non-physicians will carry out regular structured assessment on risk factors, lifestyles, and patient-reported outcomes. They will then provide special education, counseling, and psychosocial support and structured patient education and empowerment to reduce the patient risk factors and improve self-management. Whereas physicians will also provide multidisciplinary treatment based on results from the structured assessments and monitor the clinical progress regularly. So Hong Kong has a dual-track healthcare system with 50% of the doctors working in the private sector. Many patients receive care from both the sectors, literally free or cheaper medications from the HA and personalized counseling from private doctors. So we were interested in evaluating whether integrated care would be more cost-saving in a public-private partnership setting as compared to with or without integrated care in a public hospital setting. Thus, Professor Juliana Chan carried out a study on this for the Public Policy Research Funding Scheme with a report published in 2017. In the PWH-affiliated Prince of Wales Hospital affiliated to our university, we used the JADE technology to issue a personalized report, followed by group explanation to patients attending with the public clinic, with the referral for repeat assessment dependent on the doctors. This is labeled as JADE group in our study. In our university-affiliated diabetes center, Yao Zhonggit, set up in 2007, operated by trained nurses, we offer a self-paid JADE assessment program, followed by a personalized explanation of the report, an annual telephone reminder for the repeated assessment every 12 to 18 months. These patients can self-refer or be referred by their doctors to the Center for Assessment. They are labeled as JADE public-private partnership in our study. Other hospitals used the adapted JADE protocol in the EMR to perform assessment without specific follow-up action. This is known as non-JADE group in our study. I only have two more slides. So based on the collected data, we calculated the average length of stays annually stratified by 3 types of care programs and the 4 JADE risk levels. And about 66.2% of the patients were risk level 3, 22% were in level 4, and 11% were in levels 1 to 2. We projected this estimated length of stay and proportion of patients by risk levels in 400,000 patients, which was estimated number of patients with diabetes in Hong Kong at that time of the study. The JADE public-private partnership was estimated to save 391 Hong Kong dollars and 11,964 Hong Kong dollars per patient for levels 3 and level 4 JADE risks respectively, as compared to a normal HA care program. Even using a JADE assessment in an HA public hospital setting would actually save up to around 1,000 to 2,000 Hong Kong dollars per patient. We also carried out an individual patient simulation, projecting the cost reductions of these 400,000 patients over 15 years in the CDOM model. Highest cost savings were 19 trillion Hong Kong dollars from avoided end-stage kidney disease events, followed by 3.9 trillion Hong Kong dollars avoided stroke events and 780 $89 billion from avoided coronary heart disease over the 15 years. So a JADE public-private partnership program is a cost-saving program in reducing NCDs in Hong Kong for the long run. So here's my conclusion. To summarize today's presentation, we should apply novel, innovative drugs such as SGLT2 and GLP-1RA within an integrated care system with a risk stratification to maximize their impacts and make healthcare sustainable, affordable, and accessible. And JADE integrated diabetes care model is also cost-saving in the long term and improve health outcomes by reducing costs and providing coordinated and comprehensive care to patients with diabetes. Apart from clinical outcome endpoints, cost-effectiveness analysis and patient-reported outcomes should also be evaluated and monitored for the sustainability and the impact of implemented integrated diabetes care models. CAA models can also be applied to assist decision-making of adopting innovative health technologies, such as new drugs, GLP-1, SGLT2, and continuous glucose monitoring devices in our local setting. Thank you.